Hello, and welcome to this podcast, which will be covering pneumothorax. Today, we'll be discussing what a pneumothorax is, we'll be outlining the different types of pneumothorax, and finally, we'll give a quick description of the different management plans for each of the different types of pneumothorax. So what is a pneumothorax? Very simply, it is air that gets into the pleural cavity. And what can happen is you usually have the two pleural membranes very close together, which allows the lungs to expand when the chest inspires and expires. But sometimes this can become disrupted and air is able to get between the two pleural membranes. And there are three types of pneumothorax. Primary pneumothorax, when it occurs with no underlying lung pathology. A secondary pneumothorax, which occurs with an underlying lung pathology. And finally, a tension pneumothorax, which usually occurs secondary to some form of trauma. And tension pneumothorax is one of the medical emergencies that every clinician should know how to deal with. Firstly, we're going to cover primary pneumothorax and secondary pneumothorax. As I said before, the primary pneumothorax usually occurs with no underlying lung pathology, but there are certain characteristics that are found with patients who present with this. Usually they are relatively tall, and these patients often get the pneumothoraces in the apices of the lungs. The patients are often smokers. There's no clear pathophysiology for why this should be, but it's a very well-known association. And finally, patients who have connective tissue disorders, such as Marfan syndrome or Ehlers-Danlos, are often able to get complications with pneumothoraces. And because these patients usually have no underlying lung pathology, it usually affects patients in the age range of 20 to 30. The secondary pneumothorax is secondary to some sort of lung pathology, the most common one being COPD, but other ones include the granulomatous disorders, TB and sarcoid, as well as the chronic lung disease of cystic fibrosis, malignancies, and secondary pneumothorax can also occur after trauma. But the biggest one is due to COPD, and therefore the patients who usually present with a secondary pneumothorax are in the age range of 60 to 65. So how will these patients normally present? Often the patient will present asymptomatically, and the diagnosis will be made incidentally on chest X-ray. However, sometimes the patient has also got symptoms of pleuritic chest pain and shortness of breath. But when we come to examine the patient, this is when the real signs are able to distinguish it from other lung disorders. So on inspection and palpation, we'll find that the patient has a reduced expansion on the side of the pneumothorax. When we go to percuss the patient, it will be found to be hyperresonant. And when we come to auscultate, there will often be reduced breath sounds on the side of the pneumothorax. And when we come to investigate the patient, the most critical investigation is that of a chest X-ray. And here we have a chest X-ray with a radiolucency in the right side of the chest. And this suggests that it's only air and no tissue in that area, as shown by the white arrow. But also, with the red arrow, we can see that there appears to be a lung marking which is far away from the chest wall. This is the actual lung, which is basically collapsed, and this is your pneumothorax. Another investigation that can be carried out is an arterial blood gas, and this is just to analyze how well the patient is coping with the pneumothorax by analyzing the partial pressure of oxygen and partial pressure of CO2. So once we've diagnosed the pneumothorax, how do we go about managing it? The management is very well described by the British Thoracic Society guidelines, and the guidance is different between a primary pneumothorax and a secondary pneumothorax. First, we will consider a primary pneumothorax. We must first of all see how badly affected the patient is. So if the patient is short of breath, and on X-ray, if the airspace between the lung marking and the thoracic wall is more than 2 centimeters. This suggests that the pneumothorax is relatively serious. If the patient does not have either of these criteria, then we are able to safely discharge the patient because a pneumothorax usually will resolve itself. However, if the patient has got these two characteristics, then we first of all try and manage it by aspiration, in which we try and remove the air with a needle. If this is found to be successful, then we can discharge the patient. If it is not successful, then we carry out the same procedure again, and we aspirate to try and remove the air again. If this works, then we're able to discharge the patient. However, if this does not work, then we move into the most definitive treatment, which is a chest drain. And we do this by inserting a needle using an aseptic technique into the fourth or fifth intercostal space in the mid-axillary line. If this is successful, we are able to discharge the patient. However, if it is not, we should refer the patient to a chest physician for more senior help. So that is the management of a primary pneumothorax. The management of a secondary pneumothorax is actually quite similar, but because we are unable to treat the underlying lung pathology straight away, it is more a symptomatic resolution. So we're looking for, again, the same criteria: shortness of breath, and whether the airspace on chest x-ray is more than 2 centimeters. However, we also need to see whether the patient is over 50 years of age. If they do not fit this criteria, then the first line treatment is to carry out an aspiration, again very similar to that of a primary pneumothorax. But the difference is, if this is not successful, then we do not do a second aspiration, but rather go straight to a chest drain. However, if it is successful, we don't discharge the patient, we again readmit them for at least 24 hours to ensure that they do not get a reoccurrence of the pneumothorax. However, if the patient does fulfill the 3 criteria, then we go straight to a chest drain. If this does resolve the problem, then again we admit the patient for at least 24 hours. However, if it does not, then we refer to a chest physician for more senior help. Now we've covered the primary and secondary pneumothorax, we're going to go through to the tension pneumothorax. This is one of the medical emergencies. It often occurs secondary to trauma when a piece of tissue or skin acts as a one-way valve. So whenever the patient breathes in, air is drawn into the pleural cavity, but because of the valve system, on expiration, the air is not allowed out. Therefore, over time, there is a buildup of pressure on the side of the pneumothorax. This can get to such large pressures that we start to see a mediastinal shift, as shown in this X-ray. You can see that the heart and also the trachea is starting to deviate away from the left-hand side of the chest towards the right-hand side. This causes major distress for the patient, and also, if the pressure is allowed to build up, can actually lead to rupturing of some of the vessels in the mediastinum. Therefore, it is a medical emergency. So how will this patient present? Often, it will be secondary to trauma, so you may see some signs of trauma, such as a flailed chest. Also, the patient will be relatively distressed because they are in quite a lot of pain. Lastly, the patient will often be short of breath, and this will become increasingly so as the pressure builds up. But most importantly, are the signs that the clinician is able to see. Firstly, the trachea may be deviated away from the side of the pneumothorax. Also, the patient may be tachycardic and hypotensive, as well as the other signs seen with a normal pneumothorax, such as a decreased breath expansion, a decreased breath sounds, and an increased percussion note. Once we have a clinical diagnosis of a tension pneumothorax, the most important thing to remember is that the patient should not be x-rayed, because this is a medical emergency. Therefore, we go straight to management. And the management is to try and open the air pressure between the outside world and the pleural cavity. And the way this is done is by inserting a 16-gauge needle or cannula into the second intercostal space mid-clavicular line, and if this is done correctly, a satisfactory hissing sound is heard. Once this is done, a chest drain can be inserted, as well as other investigations such as a chest X-ray. This concludes our podcast on pneumothorax. So to summarize, there are 3 major types of pneumothorax: a primary pneumothorax, a secondary pneumothorax, and a tension pneumothorax. And we've outlined the basic management plans for all of them. And the most important thing to remember is the tension pneumothorax is a medical emergency and therefore must be treated appropriately. Thank you.